Hi, welcome back to your prescription for medication education. My name is Yenmi, and I'm a pharmacist. And if you enjoy learning about medications as much as I do, then I think this is the right channel for you. Today, I'll be talking about alpha 1 blockers. Just like last time, I'll go ahead and start the video with 5 questions. By the end of this video, you should be able to answer all 5 questions with no problem, I hope. Question number 1, a 72-year-old male with benign prostatic hyperplasia is taking doxycycline. He is started on tadalafil 20 milligrams as needed for erectile dysfunction. Shortly after, he reports dizziness and near syncope when standing. Which of the following best explains this interaction? A. Increased metabolism of tadalafil via CYP3A4 induction. B. Additive vasodilation leading to decreased systemic vascular resistance. C. Competitive inhibition of alpha-1 receptors by tadalafil. D. Increased preload due to venous constriction. Or E. Reflex bradycardia due to vagal stimulation. Question number 2. Which of the following alpha-1 blockers is associated with the highest risk of intraoperative floppy iris syndrome? A. Prazosin. B. Doxycycline. C. Terazosin. D. Tamsulosin. E. Alfuzosin. Question number 3. A 78-year-old female is taking prazosin for hypertension. She reports multiple falls over the past month. Her blood pressure is well controlled. According to current geriatric recommendations, what is the most appropriate next step? A. Increase the dose to improve blood pressure control. B. Switch to another alpha-1 blocker with longer half-life. C. Continue therapy and add a beta blocker. D. Discontinue prazosin and initiate alternative antihypertensive therapy. Or E. Add fludrocortisone to prevent orthostatic hypertension. Question number 4. Which of the following best explains why alpha-1 blockers are associated with orthostatic hypotension? A. Decreased cardiac contractility. B. Increased venous return during standing. C. Impaired vasoconstrictive response due to alpha-1 receptor blockade. D. Increased parasympathetic tone. Or E. Direct suppression of the SA node. And the last question, question number 5. A patient stabilized on doxycycline is prescribed sildenafil. Which of the following strategies is most appropriate to minimize the risk of hypotension? A. Initiate sildenafil at the highest dose and titrate down. B. Take both medications at the same time to reduce variability. C. Discontinue doxycycline prior to starting sildenafil. D. Initiate sildenafil at a low dose after stabilizing alpha-1 blocker therapy. Or E. Increase sodium intake prior to dosing sildenafil. I recently had a friend of mine watch some of my videos and give me some feedback. He basically suggested that I should add more visuals, so I went ahead and done that today, and hopefully that helps with the learning process. Before jumping into alpha-1 blockers, let's briefly review which molecules are responsible for normally activating adrenergic receptors. Catecholamines are a class of amines that are derived from the amino acid tyrosine that function as neurotransmitters and hormones. Catecholamines contain 2 key components, the first one being a catechol moiety, which is a benzene ring and 2 hydroxyl groups, and the second component is an amine group. Important catecholamines include norepinephrine, also referred to as noradrenaline, and epinephrine, also referred to as adrenaline. Dopamine is also another catecholamine. Alpha-1 adrenergic receptors are G protein-coupled receptors that mediate sympathetic nervous system effects. When norepinephrine and epinephrine bind to these receptors, they activate GQ proteins, which stimulate phospholipase C. Phospholipase C activation leads to increased levels of second messengers such as inositol 1,4,5-triphosphate and diacylglycerol. IP3 binds to receptors on the sarcoplasmic reticulum, which triggers the release of stored intracellular calcium, while DAG activates protein kinase C. Together, these signaling pathways promote smooth muscle contraction. Alpha-1 receptor blockers work by selectively blocking postsynaptic alpha-1 adrenergic receptors, which blocks the vasoconstriction in arterioles and veins. There are 3 types of alpha-1 receptors, which are alpha-1A, alpha-1B, and alpha-1D. Alpha-1A is found in high amounts in prostate smooth muscle and the bladder neck. Alpha-1B and alpha-1D receptors are more widely distributed in vascular and central nervous system tissues. Alpha-1 receptor antagonists may be reversible or irreversible when interacting with receptors. Reversible antagonists can dissociate from the receptors and can be overcome with higher concentration of agonists. Examples of alpha-1 blockers include prazosin, doxazosin, and terazosin. In terms of efficacy, alpha-1 blockers reduce systolic blood pressure by about 8 millimeters and diastolic blood pressure by about 5 millimeters compared to placebo, and these numbers likely may actually be an overestimation due to the limited number of quality of available trials. Their adverse effects include orthostatic hypotension, dizziness, asthenia, and fatigue. Contraindications include any hypersensitivity to parts of the formulation, and some of the warnings include floppy iris syndrome, heart failure, first dose response, and inclusion in the Beers criteria. Their clinical uses include benign prostatic hyperplasia and hypertension. Prazosin was the first selective alpha-1 antagonist. It acts on all three subtypes of alpha-1 receptors. It's available in 1, 2, and 5 milligram capsules. It has a relatively short half-life of about 2.5 to 3 hours. Its initial recommended dose is 1 milligram by mouth twice a day to 3 times a day. Prazosin has a high first-pass hepatic metabolism with an oral bioavailability ranging from 44 to 69%, and its metabolized are almost completely excreted in bile. What's interesting is that the FDA does not provide specific dose adjustments for hepatic impairment. It's likely that hepatic impairment can lead to increased bioavailability and reduced clearance of prazosin. Although it's not a preferred agent in the treatment of pediatric hypertension, it does have a niche use for scorpion and venomation. Drug interactions include milsaperidone and phosphodiesterase 5 inhibitors. Terazosin only has one brand name available, which is Tisruli, an oral solution. Just like prazosin and doxazosin, the initial starting dose for hypertension is 1 milligram PO once a day. It has a half-life of about 9 to 15 hours, and you may see it dosed twice a day. Doxazosin's brand name is Cardura, and it's available in an immediate release and extended release formulation. It has a much longer half-life than prazosin, about 6 to 10 times longer, which allows it to be dosed once a day. The extended release formulation Cardura XL is indicated for the treatment of BPH and should be taken in the morning with a meal. Doxazosin was part of the original treatment arm of the All-HAT trial, but its inclusion was stopped early because it showed a higher risk of heart failure and combined cardiovascular events compared to chlorthalidone. I've included phentolamine in this video despite the fact that it's a competitive non-selective alpha-adrenergic receptor antagonist. When given IV, its onset of action is 1 to 2 minutes and its duration of action is about 10 to 30 minutes. By blocking alpha-1 receptors, phentolamine causes vasodilation of vascular smooth muscle. In addition, blockade of presynaptic alpha-2 receptors increases norepinephrine release, leading to reflex tachycardia and increased cardiac contractility via beta-1 receptor stimulation. It has several indications, but I've included it because it can be used to treat a hypertensive crisis due to catecholamine excess such as pheochromocytoma, cocaine toxicity, amphetamine overdoses, or clonidine withdrawal. The recommended dosing is an IV bolus of 5 milligrams with an additional bolus given every 10 minutes as needed to achieve the target blood pressure, up to a maximum dose of 50 milligrams per 24 hours. It should be used with caution in patients with coronary artery disease because reflex tachycardia may increase myocardial oxygen demand. Its side effects include arrhythmias, hypotension, and headaches. There are no clinically meaningful differences in blood pressure lowering efficacy between prazosin, terazosin, and doxazosin. Over time, they tend to increase extracellular fluid and cause plasma volume expansion, leading to weight gain, which decreases their antihypertensive efficacy, especially in patients consuming usual amounts of dietary sodium. Due to systemic vasodilation and reduced blood pressure, the body tries to compensate by increasing sodium reabsorption via the kidneys. Fluid retention typically manifests as 1 to 2 kilograms of weight gain, attenuation of blood pressure lowering, and an increased risk of heart failure exacerbation. Because of this, class effect alpha-1 blockers are not recommended as first-line therapy due to inferior cardiovascular outcomes compared to diuretics, especially for increased heart failure and stroke risk. As a side note, alpha-1 blockers do have a favorable effect on lipid profiles, but this does not translate into improved cardiovascular outcomes. When reviewing adverse effects associated with alpha-1 blockers, it's important to discuss the term first dose phenomenon, also referred to as the first dose response. This term refers to an acute hypotensive response which often manifests as orthostatic hypotension with syncope, which occurs with the first dose of an alpha-1 blocker or when therapy is reinitiated after interruption. The first dose effect results from blockade of alpha-1 adrenergic receptors on both resistance arteries and capacitance veins, which impairs reflex vasoconstriction upon standing. This usually occurs in the first 30 to 90 minutes of the first dose. To reduce the risk, it's critical that patients be started on the lowest dose possible, and it's quite easy to remember because all three alpha-1 blockers I reviewed in this video have a 1 milligram strength, so if you remember that they are an alpha-1 blocker, then you can make the connection to start patients on the 1 milligram dose. Risk factors for first dose syncope include intravascular depletion, beta blocker use, and older age. Prevention strategies include to take the medication at bedtime, ensure they stay hydrated, inform the patient to get up slowly from a sitting or lying position, and slowly titrate the dose if needed. Unfortunately, orthostatic hypotension can persist throughout treatment, especially with short-acting prazosin. Asthenia is a medical term describing generalized weakness, fatigue, and lack of energy or strength. It is subjective rather than true muscular weakness termed myasthenia. Asthenia is one of the most common adverse effects of alpha-1 blockers and can lead to discontinuation of therapy. The exact mechanism why this occurs is not fully understood, but it's believed to be due to reduced blood pressure and cerebral perfusion. Another proposed reason why this occurs is that alpha-1b and alpha-1d receptor subtypes are widely distributed in the central nervous system, and their blockade may contribute to fatigue and tiredness. It's important to inform our patients because this can occur early in therapy or persist throughout treatment. Intraoperative floppy iris syndrome is an intraoperative finding during cataract surgery. It consists of three main characteristics. Number one, iris billowing/floppiness. Number two, iris prolapse. And number three, progressive intraoperative miosis. Normally during cataract surgery, the iris is firm and stable, but in intraoperative floppy iris syndrome, the iris becomes loose and floppy and billows inward and outward in response to fluid flow. The iris prolapses toward the side port incisions and the pupil progressively constricts despite standard preoperative dilation. There are several proposed mechanisms as to why this occurs. The iris dilator muscle is innervated by sympathetic fibers acting on alpha-1 receptors. Alpha-1 blockers, especially alpha-1A selective agents like tamsulosin, causes the muscle to become relaxed and unable to maintain tone. IFIS can occur even in patients who have discontinued alpha blockers prior to surgery, which suggests that chronic alpha blockage can induce permanent structural changes in the iris. It's important that we advise our patients to let their surgeons know they are an alpha-1 blocker because when surgeons anticipate IFIS, they can employ compensatory techniques, which can reduce complication rates. A prospective multi-center study found only 0.6% posterior capsule rupture rate when experienced surgeons used IFIS management strategies. Prescriber awareness of IFIS has historically been low, highlighting the need for better communication. Non-selective alpha blockers like doxazosin, prazosin, and terazosin have a lower risk compared to tamsulosin in patients with expected cataract surgery. The 2023 American Geriatric Society Beers criteria recommends avoiding peripheral alpha-1 blockers as antihypertensive agents in adults 65 and older due to the risk of orthostatic hypotension, syncope, and falls. As we age, our baroreceptor reflexes are impaired and falls can lead to hip fractures and head injuries. Alpha-1 blockers have not demonstrated reduction in cardiovascular morbidity and mortality in older adults, unlike the previous antihypertensive classes I covered in my last couple of videos. I want to make it clear that the use for BPH is not contraindicated. The Beers criteria specifically targets alpha-1 blockers used as antihypertensives. Use for lower urinary tract symptoms due to benign prostatic hyperplasia is not explicitly prohibited, but caution is still warranted. The Journal of the American College of Cardiology deprescribing notes that adverse drug reactions occur in up to 35% of older outpatients and 44% of hospitalized older patients, and alpha-1 blockers are among the cardiovascular medications that should be avoided. Essentially, when an older adult is on an alpha-1 blocker for hypertension, deprescribing should be considered. Milsaperidone, brand name Bysanti, is a newly approved atypical antipsychotic indicated for the treatment of schizophrenia in adults. It has alpha-1 adrenergic antagonist properties like most atypical antipsychotics. Because of this, we can expect to see an additive effect when combined with alpha-1 blockers such as orthostatic hypotension, dizziness, and syncope. In its prescribing information, it states to avoid concomitant administration of Bysanti with alpha-adrenergic blocking agents. The interaction between phosphodiesterase 5 inhibitors and alpha blockers results in additive vasodilation and hypotensive effects. This effect varies by the alpha blocker, but a study involving doxazosine and tadalafil 20 mg showed a mean maximal decrease in standing systolic blood pressure was 9.8 millimeters greater than with placebo. 28% of subjects had standing systolic blood pressure of less than 85 millimeters of mercury. Because tadalafil has a longer half-life, somewhere between 17 to 20 hours, the interaction may persist longer than with sildenafil or vardenafil. When patients require taking both classes of medications, it's important to initiate one class first and have the patient stabilized before adding on the second class. With shorter-acting phosphodiesterase inhibitors such as sildenafil, separating administration times can minimize the risk for hypotensive effects. Okay, so the answers to the questions at the beginning of the video was number 1, Bravo, number 2, Delta, number 3, Delta, number 4, Charlie, and number 5, Delta. And that was your dose for medication education. I do hope you enjoyed today's video. If you did, please consider subscribing and sharing my channel. It would mean a great deal to me. Thank you, and have a great day.